My name is Matt McCambridge. I'm the Chief Quality Officer at Lehigh Valley Health Network. I'm also a pulmonary and critical care physician. I've been practicing pulmonary and critical care medicine for about 20 years, and I've been the Chief Quality Officer for about a year now. I wanted to tell you some of the work we're doing here at Lehigh Valley Health Network around sepsis. First, I wanted to start with a case presentation. This is a 34-year-old teacher, this nice lady sitting upright holding the baby. He's from a city that's about an hour from here. She's from Scranton, Pennsylvania. She already had a 2-year-old at home, and the 2-year-old became ill. This nice lady was 28 weeks pregnant with her second child, who she's holding there, and she became ill. She went to the local outside hospital, and at the outside hospital she was admitted for about 24 hours. She became progressively sicker. We have a relationship, a maternal fetal medicine relationship with the outside hospital, and she was transferred down here. She was so progressively ill with pneumonia by the time she got to our hospital, which is about an hour away, she needed to be intubated. And after she was intubated in the intensive care unit, she became sicker and sicker and sicker and sicker. She had abnormalities in her hemoglobin, abnormalities in her platelet count, and it turned out that she was infected with an adenovirus, a routine virus, that ended up transitioning and causing a disease called hemophagocytic lymphohistiocytosis. Not a very common disease. So she was profoundly critically ill on the mechanical ventilator. The baby was in distress, so she had an emergency section right in the room. The baby was then taken to the neonatal intensive care unit. She was emergently transferred to our open heart unit where we do ECMO, extracorporeal membrane oxygenation. And over the next 9 days on ECMO, she slowly improved. She needed to receive hemodialysis continuously during that time period as well. There was a period of time where she was bleeding so profusely into her left chest that our 3 cardiothoracic surgeons had to pretty much be in the operating room with her the majority of one day. They finally got the bleeding under control. As you can see from this slide, there was 93 total providers that took care of her during that 9-day period. 30 nurses, 12 tech partners, 20 respiratory therapists, 17 physicians, 14 other therapists, physical, occupational, and speech therapists. She had 119 units of blood products, 48 units of packed red blood cells, 6 of FFP, 29 platelets, and 36 of cryoprecipitate. And we were so happy that she survived and did well. She was septic. She suffered from ARDS. You can see she's standing there. The woman on the left standing is Karen, one of her nurses in the open heart unit. The woman in the middle is Dr. Lisa Lindauer. She's one of our intensivists. And then the man on the right is Matt. That's the patient's husband. And then she's holding her baby, and I think the baby's name is Jacob. So it was a really wonderful outcome, and we're proud of what we've done here with respect to sepsis and other types of critical illnesses. And I just want to tell you a little bit about that. The bottom line here is our observed to expected overall hospital mortality from 2008 through 2015. And you can see that the trend line of those data points is slightly going in the wrong direction. Observed to expected mortality, it's always better for it to be less than 1. You want fewer people dying that are expected to die. And this was approaching 1, which is not where we wanted it to be, and we started looking a little bit more further into this. And what we found was our sepsis mortality, which is this sloped line that's more acute, our sepsis mortality was much higher than our overall mortality. And we started looking into that a little bit more, and sure enough, we needed to fix some processes and systems around sepsis. This slide is a slide that shows at our hospital, and I would argue at most hospitals, is there's at least a correlation between when the sepsis mortality is good, the overall mortality is good, and when the sepsis mortality is high, the overall mortality tends to be high. That's what those 2 arrows are showing. So we thought at least there was a correlation with 2,200 septic patients a year at our hospital. Of the 49,000 admissions, we felt this was something we needed to focus on. So we started looking around the country. We found a couple of programs that we wanted to emulate. One was at North Shore Long Island Jewish, which I believe now is known as Northwell. And North Shore Long Island Jewish has been on a sepsis journey much longer than we've been. You can see from this graph that their sepsis absolute mortality was about 32 or 33% when they started, before they started working on sepsis in 2008. And then they put a task force together, they created an ED algorithm, they joined an IHI collaborative, and you can see their mortality is now one of the best mortalities in the country. This is a huge network of hospitals. We talked to them, learned a lot of good points from them. So that's really where we started, and actually learned about their program at the 2015 IHI meeting in Orlando. What we did was we formed a large task force to look at all different aspects of sepsis and we learned that 90% of our patients at our hospital come to the emergency department with sepsis, and 10% develop it while they're in the hospital. So you can see on this slide, there's a present on admission aspect to sepsis, and there's an after admission subcomponent of sepsis as well. And you can see what we did was we had members from pharmacy, emergency department of course, physicians and residents, hospitalists, and then IS with enterprise analytics played a big component in this, and then you can read the rest. Lots of people on both sub-task forces to help us improve overall sepsis mortality. And then we had to take the present on admission sepsis and break it up into 4 further subgroups. The group 1A was physical and operational changes that needed to be made to the ED. 1B was educating people on sepsis where we were right now and the transition of care, focusing on the residents. 1C was how are we going to provide reporting and feedback after a provider has taken care of a patient with sepsis. And then the last group was educating the EMS staff for pre-hospital care. So this is a busy timeline, but we felt we couldn't wait 2 years to get this live, so we put 35 meetings together over a period of 5 months, from January 1st, 2016 to May 1st, 2016. So many different meetings focusing on flow diagrams, algorithms, order sets, changes that we needed to make to improve the care of patients with sepsis in our community. This is how we used health information technology. This is a truncated picture of our algorithm that we put together using some of our information technology to do this. And you can see it starts at the very top as a patient walks into the emergency department. There's laboratories in the middle, and then there's appropriate antibiotics on the left side of your screen, and different decision points along the way. This took us a long time. We had to develop the flow first of how the patients were going to flow through our system. We probably met 10 times just getting this right. And then what we did, one of the nice things about being an Epic hospital is that you have access to other Epic hospitals' order sets. So we started looking around for order sets that we could look at and maybe take some things from. And one of the ones we started with and we liked was all the way out in California at Stanford, which was a very good order set. We took that order set and we modified it for our needs, and then actually we modified it again. So it doesn't really look anything like the Stanford order set, but it was a nice place to start, and you're all welcome to start with this one that we've created. So you can see on this initial thing we had to change was we actually had to create the order set, and then we had to make sure that the lactates were correct, the initial lactate and then the repeat 3-hour lactate. We focused on this slide on, again, making sure that that was done correctly. And then this one here was blood cultures, making sure they were done before the antibiotics were infused. And then IV fluids, making sure that the IV fluids were given at 30 milliliters per kilogram, and the type of IV fluid, normal saline. So this was very important. So first making the flow diagram. I believe we used Visio to make the flow diagram, and then we used Epic to create our order sets. That was very, very important. This is very important, and our nurses anecdotally in the emergency department would say that this was potentially the biggest thing that we did was we looped in the pharmacist using Epic almost immediately when the first order was put in, so the pharmacist could get us those antibiotics almost immediately. So it's a 3-hour bundle by CMS that we're supposed to give the antibiotics, and we think that's too long. We think it should be given as quickly as humanly possible. Could potentially be the most important thing for helping to save a septic patient's life. So at this point, I'd like to introduce Dr. Don Levick. Don is the Chief Medical Information Officer here at Lehigh Valley Health Network, and he's going to show you how we use a Tableau in our sepsis reporting.
Thank you, Dr. McCambridge. This is the tool we utilize to monitor our performance regarding care of patients with sepsis. We developed this tool over several months. It utilizes 79 different metrics and is calculated using vital signs, laboratory results, orders, order sets, protocols, nursing actions, and other parameters. Currently, the table contains over 5 million encounter rows, and the data is updated daily. Looking at the overall layout, you can see there are various parameters that are tracked based on best evidence and reporting requirements that our sepsis team has determined. Parameters such as mortality, length of stay, and compliance with standard care bundles are included. Focusing on the top of the model, the tabs represent the various aspects of sepsis that are followed, such as protocol adherence, encounters, volume information, readmissions, and order set compliance. Based on security, the user can actually get to patient-level data from within this model. And if the model is launched from within our electronic health record, the user can access the patient's chart directly from this patient data list. The row of drop-down menus below the overview are the various filters that can be applied to the data. These filters include various aspects of sepsis diagnosis that can be used to view the data based on need. The choices represent standard definitions for sepsis, severe sepsis, SIRS, which is sepsis inflammatory response syndrome, and the patient's coded as sepsis for the hospital stay. If a user is unclear of a definition, the glossary page is available as one of the tabs along the top. Focusing on the glossary, if you hover over one of the glossary entries, it shows the full definition of the item as a pop-up. Back on the main overview screen, I'll now demonstrate some of the functionality of this model. As noted, there are tabs across the top that allow for more detail regarding various aspects of sepsis and the care provided. Clicking on the Sepsis Protocol tab brings us into this screen. In the Sepsis Protocol tab, various filters appear across the top under the tab title. The Select a Measure, as highlighted, is the most important, as we can evaluate our performance for various aspects of evidence-based sepsis protocol steps and the standard 3 and 6 hour care bundles. On this screen, the performance for measuring lactate is shown over a 12-month period. Overall compliance and compliance based on the sepsis flag are shown, with heat mapping added to the ability to focus on change or problem periods. The screen also displays top performing departments, which are displayed near the bottom and on another screen. I have now moved over to the Mortality tab, which displays the mortality rate over time based on the sepsis filter and various associated demographic data. All of the screens allow for drilling into specific displayed parameters, such as month, age, department, etc. The user can click on a parameter and the screen will automatically refresh. On this screen, the age parameter has been filtered to only display data on patients with a sepsis diagnosis, note the filter at the top, and in the age range of 51 to 66 years old, as noted by the red box lower left. This functionality allows for discovery in addition to review of performance. The ability to easily filter the data facilitates the investigation of what-if scenarios and testing hypotheses such as, what is our mortality for patients in this age band who develop sepsis while in the hospital, and how does it compare to patients who present in the ED? The power of these screens has really allowed us to investigate both our performance as well as perform these what-if investigations. Returning to the overview screen, you can now appreciate the power of this tool. It was incredibly complex to develop and validate. However, now it is an essential tool in our ability to monitor and improve our performance as we care for sepsis in our hospital and our community. We'll now return to Dr. McCambridge as he will discuss the value derived from the sepsis team and our utilization of this tool and other data.
Thanks very much, Don. If you look at the value that we derived from this program, this is our overall control chart showing our overall hospital mortality. And you can see that our overall hospital mortality, observed to expected mortality now, from September of 2015 through July of 2017 is definitely going in the right direction. The trend line is going downward. The observed to expected mortality last month is around 0.8. Meaning fewer patients are dying than are expected to be dying in our hospital, which is excellent. The first slide was for our bigger hospital, we call LVH, and this one was for LVHM, which is a 180-bed hospital. Same thing is true. Nice downward trend in our mortality. And then our sepsis mortality, we truncated this control chart to being about 15 points as opposed to like 25 points. But if I were to go out further, there was a significant reduction in our overall sepsis mortality at both hospitals by changing our processes. And when you look at ours, we use Vizient as our overall benchmarking database to see how we're doing with respect to quality and patient safety. You can see our total inpatient mortality now in the Vizient database is 12th out of 140. For post-surgical is 11th out of 140. For urology, OB, gynecology, gyn-onc, HIV, all tied for first. Burn is 5th out of 57 hospitals. Cardiac surgery is 7th out of 118 hospitals, and medical oncology is 8th. We just got back from the Vizient conference over the weekend, and we learned that Lehigh Valley Health Network is overall 8th best in the country for the quality and accountability score in the Vizient database, and we think that a lot of it has to do with the way we've changed our processes, not only around sepsis, but in other diagnoses. So things we're working on going forward. This is a slide that shows the difference between, again, what I said earlier, present on admission mortality and non-present on admission mortality. The blue line is present on admission mortality. Those are the patients who come to the emergency department with sepsis and how they do. And the left side of the screen is Lehigh Valley Hospital, that's the big hospital. And the right side of the screen is the smaller hospital, one of our smaller hospitals, Muhlenberg Hospital. You can see both sides of the screen. The blue line is present on admission, and present on admission mortality is about 10%. It looks like it's decreasing, and that's where our main focus has been. The green line is patients who develop sepsis while in-house, either after surgery or after they were admitted for one reason or another, and that mortality is quite a bit higher, as you can see, anywhere between 30 and 40% mortality. It's fewer number of cases, but it's a very high mortality, and this is where we're focusing next. So the way we're focusing on those patients who are admitted to the hospital, again, it's about 3 or 4 patients a day that transfer from a lower level of care to a higher level of care. We're using Epic to help us highlight where those patients are within the 1,000 patients that are admitted to the hospital. So this is our sepsis BPA, our best practice advisory, and we're teaching Epic to look through the temperature, the white cell count, the heart rate, the respiratory rates, oxygen saturation, and mean arterial blood pressure, and then alert either the nurse or the physician at the bedside that this patient may very well have sepsis, and then we embed into this BPA the sepsis algorithm I showed you from before, and also the sepsis order sets. So now I will tell you, we went live with this about a week ago, and it's working well on the floor, on the medical floors. We've held it out of the ICUs because it would be triggering too often. And in the emergency department, we're having to do further modifications to get it so it's not too overly sensitive, so it's not firing all the time. Okay, now one other thing I want to show you is there's a whole other phase using technology that we need to evaluate sepsis. And as all hospitals in America start taking on more financial risk, it's important to understand what's happening to the patients all across the continuum. I know this is a wordy slide, but what we did is we looked at December, all the patients who were admitted for sepsis in December of 2016. And we found that of the 253 patients that were admitted during that month, 87 of them were already in some type of risk arrangement, whether it was with MSSP or one of our local insurance companies. 87 of the patients were already under some type of risk arrangement. And when we looked at those patients, 84 of those patients were considered very high risk. They were very expensive to care for. Their per member per month contribution was $7,427. When you followed those patients over a period of a year, 343 of them came back to the emergency department. There was 343 readmissions during that year for a 53% readmission rate, and then they were a fairly old group of patients. Also, something we're working on right now is we feel that our readmission rate is very, very high because about 18% of those patients really don't have a primary care doctor. So we're using the technology, Epic and Enterprise Analytics, to now help us identify those patients who have sepsis, who are at high risk to be readmitted because they really don't have a primary care physician. So many things that are happening with respect to technology and sepsis right now. And I want to show you this slide. So we further took 43 of those 87 patients and analyzed them further, looking at the exact cost per case. You can see on the top line of the 43 episodes of patients who had sepsis, it cost us $1,375,616 to take care of those patients. So that value divided by 43 is $31,991 per patient it costs us to care for these patients. And if you look at the bars across the bottom, we can now analyze using the integration between clinical data and administrative data, Epic and Optum. We can figure out where we're spending that money. So you can see the light blue bar is the anchor admission. We're spending 48.7% of the dollars on the anchor admission. But the next two things I'm going to mention are very, very important. What we're learning more is 22% of the dollars, the green box, are being spent when patients are being readmitted to the hospital within a year of leaving for that anchor sepsis admission. And even more importantly is we have a high utilization of skilled nursing facilities. So you can see 9.7% of the dollars, the light green bar, is being spent on skilled nursing facilities. So we think if we're going to be successful for our patients, almost no patients want to be admitted to the hospital. They certainly don't want to be readmitted to the hospital. We need to decrease the number of readmissions. Many patients would prefer to go home rather than a nursing home, and we need to increase the purplish box. So the purplish box is home care. The percentage of patients going home to home care as opposed to being readmitted to the hospital or using a skilled nursing facility. So we're learning so much more about these patient population when you combine EPIC, which is the clinical data, with Optum, which is the administrative data, and we think we're on the verge of something important for the people in our community. It's just another way of looking at what I just showed you. If you look at these bars, the tables, again, the anchor admission, the anchor plus home care, anchor and then readmission, and then look on the right side, the dark one, the one that stands out the most is the one that says anchor, readmission, and skilled nursing facility. And you can see it cost us for that one patient $153,000 to care for that patient. So we need to identify the patients and do a better job of taking care of them all across the continuum. And we believe that the marriage of EPIC, which is the clinical data, and Optum, which is the administrative data, will really help us do this going forward. We're very excited about this. You can also break it down by physician or physician group. The orange bars on the right side of the screen are the physicians, so we can tell if there's a particular group or a physician that's having trouble with increased costs or utilization of nursing homes or utilization of readmissions and that type of thing. So it's very powerful, and you can tell days since discharge to readmission. So that's where we stand. So at LVH, our mission remains to heal, comfort, and care for the people of our community by providing advanced and compassionate health care of superior quality and value, support by educating and clinical research. And we're really proud of the sepsis program. We're developing another approximately 30 pathways this year, and we're hopeful by fixing our systems and our processes that we'll be able to provide even better care for the people in our community.